Hello everyone. My name is Zena Rockowitz. I'm a program supervisor at NYU's Alzheimer's Disease Research Center. Thank you for attending today's Learn at Home. We have Dr. Arlene Foston here, and she's going to present on brain donation, what we learn, and how it can help. So as a little background, Dr. Foston is a clinical assistant professor of pathology at NYU Langone, a board certified in anatomic pathology and neuropathology. She attended SUNY Downstate College of Medicine at the City College of New York, where she earned a combined BS MD. She went on to complete residency in anatomic and clinical pathology at the Mount Sinai Medical Center and neuropathology fellowship at the NYU Langone Health Center. Since 2011, she has worked in clinical and neuropathology cores at the Alzheimer's Disease Research Center to diagnose Alzheimer's disease and research neuropathology in autopsied brains. Dr. Foston's work has ranged from autopsy coordinator, cognitive tester, community outreach and educational leader, clinician, researcher, biorepository director, neuropathologist, and as of 2017, associate director of the ADRC Neuropathology Core. Her clinical and research experience in neuropathology has reinforced her dedication to making the kinds of groundbreaking discoveries in Alzheimer's disease pathology that may one day lead to treatment and perhaps a cure.
Thank you, Zena. Thank you for the introduction. Good afternoon, everyone, and thank you for taking this time to spend the afternoon with us just to get some insight on brain donation. Why do we do it, and what can we learn from it? All right, I'm going to just turn off my camera so we're just not distracted. Okay. So first, let's talk about what is dementia. Okay, dementia is a broad category of brain diseases that cause a long-term and often gradual decline in memory or other thinking skills, severe enough to affect a person's daily functioning. So that's the key term there, right? Do you have enough of a deficit to affect your daily functioning? Dementia is considered a syndrome because it's thought of as a group of thinking and social symptoms that interfere with these daily functioning. And when I talk about daily functioning, I mean from the time you wake up to the time you recognize you have to brush your teeth, you have to get dressed, how to get dressed, where to go, where you have to go. Those are all the things we take for granted, but are considered our daily functioning. Now, people can have more than one type of a dementia, and that is termed mixed dementia. Dementia is an umbrella term, and it's used to describe a range of symptoms associated with cognitive impairment. Alzheimer's still remains the most common cause of dementia, followed closely by vascular dementia, things that will give you cause atherosclerosis or anything that would give you risk factors for a heart attack or hypertension or diabetes. Vascular dementia is then followed by Lewy body disease, being the third most common cause of dementia. And lastly, frontotemporal disease, which is a disease that the first thing that you really notice are social inappropriateness and changes in behavior, a rare type of dementia. So causes and types of dementia, before one jumps to Alzheimer's disease, there are a multitude of reasons why someone could be forgetting or not seeming as sharp as they are. And the different causes can be reversible. So we have neurodegenerative disorders where Alzheimer's disease falls under, Lewy body disease, as I mentioned, Parkinson's disease, frontotemporal disease, which I also mentioned, the change in behavioral behaviors, I guess, behavioral change in an individual. Again, as I mentioned, vascular disease is another cause, large vessel disease or anything that would put you at a risk for heart attack or strokes. Another cause of dementia could be infectious, inflammatory, or immune-mediated disorders. These are disorders that are preventable. If you're able to prevent yourself from attaining an infectious entity such as meningitis or syphilis. And in many cases too, these diseases can be treated, such as viral infections. HIV infection, unfortunately, we don't have a way to treat it or to, I guess, get rid of it completely, but the effects can be mitigated so that if someone is cognitively impaired, they can return back to baseline. Other cause of dementia, known as prion disorders, CJD, or at a time, if you're old enough, it's called like mad cow's disease. There was a time when that was a worry. That is a more progressive type of dementia, where from the onset of symptoms to death is around 2 years or less. And those are not reversible. There is no cure for prion disorders. Other types of dementia, which are certainly reversible, are toxic and metabolic disorders. Alcoholism can cause cognitive decline or a decline in your daily functioning. Vitamin B12 deficiency, folate deficiency, or really any vitamin deficiency can make one seem less sharp or seem impaired. Other conditions such as tumors, where they can be detected, and if they're causing some kind of pressure in the different areas of the brain that are in charge of memory or the part of the brain that makes your personality, those can be impinged upon by a mass. Also hydrocephalus, a condition where you have too much cerebrospinal fluid in your brain, could also be a cause of dementia, because again, it would be causing pressure to different areas of your brain. And so in which case that that excess of cerebrospinal fluid would have to be removed, and that can also be done. Traumatic brain injury is another cause of change in behavior or memory. It's football season, and it's not a popular opinion. However, there has been research over the years and over decades to suggest that traumatic brain injury, for example, but not limited to, sports do and can affect one's cognition as well as their behavior. So core mental functions of at least 2 of these 5 domains must be significantly impaired to be considered dementia. And these 5 domains are memory, communication and language, ability to focus and pay attention, reasoning and judgment, and visual perception. So once you have at least 2 of those domains impaired, you're considered to have a form of dementia. This is just a schematic to demonstrate the different areas of your brain and how they function. So the most anterior part of your brain is known as the frontal lobe. It's in charge of intelligence, judgment, and behavior. Your parietal lobe, just behind there, is in charge of language for the most part. Most posteriorly, your occipital lobe is in charge of visual perception. That is, when you see something, you know how to use it. You see a pen, you know how to use it. You see your phone, you know exactly how to use it, and so on. Your temporal lobe, of course, last but not least, which is in charge of your memory and houses your hippocampus as well as other structures. So when you have or develop Alzheimer's disease, there is a sequential order in which the disease I guess, attacks the brain or places itself in the brain. And these are all the different areas of your brain can be affected by Alzheimer's disease, depending on if your impairment is mild, moderate, or severe, consider, as in late stage. In late stages of Alzheimer's disease, all of these, sorry about that, all of these areas are affected. Alzheimer's disease, as I stated, still remains the most common cause of dementia amongst older adults. 50 to 75% of all cases are due to Alzheimer's disease. Alzheimer's disease is now the 7th leading cause of death in the United States. It used to be the 6th prior to COVID-19. I'll show you a slide so that you can see where that falls in. And there are 5 main groups with different molecular genetic associations with Alzheimer's disease. So the most common type of Alzheimer's disease is sporadic late onset Alzheimer's disease. In other words, nobody knows why you get it. There is no genetic disposition. That is the most common form. Although you'll hear a lot about genetic testing and ApoE status, 3 versus 4, those are familial cases. They can be familial late onset cases. However, as much as they're discussed, they are uncommon. They're not the most common form of Alzheimer's disease. Another type, even more rare, is familial early onset Alzheimer's disease. That's a form of Alzheimer's disease that occurs way earlier than even the 60-year-old age mark. It can occur as early as someone in their 40s and 50s. Another type of Alzheimer's disease is that associated with Down syndrome, which is well documented. And also Alzheimer's disease can be associated with other degenerative diseases. This is just a slide that I thought that was interesting to show. As COVID-19 has shifted the leading causes of death in the United States. Leading the top is still heart disease, followed by cancer, followed by accidents, and then COVID-19 devastatingly took the number 4 spot, followed by stroke, chronic lower respiratory diseases, Alzheimer's disease, landing in 7th, followed by diabetes, nephritis, nephrotic, and nephrosis are various renal diseases, and chronic liver disease rounds out the top 10. So why is brain autopsy important? Examination of the brain tissue after death in this year of 2024 still continues to be the gold standard for definitive diagnosis of dementia. Now, I emphasize gold standard because prior to, I want to say, maybe 2020 or 2021, I'm not sure of the exact year, it used to be the only means of following a definitive diagnosis for dementia. However, these days, there has been a lot of research investigating biomarkers in the form of blood tests and imaging in the form of PET scans to measure amyloid and tau, which are the two entities that are responsible for Alzheimer's disease. And I'll get into that a little bit later. But the idea is we want to be able to, as an Alzheimer's disease community and research community, to be able to detect Alzheimer's disease as soon as we can. And that means before you even pass. These biomarker testings are still in the research phases. They're not made clinically and widely available as of yet, and they still need to be compared to the gold standard of which is autopsy, hence making autopsy and examination of brain tissue still very, very important at this stage. Brain autopsy is also important because it enables the study of molecules involved in the disease process that could lead to the development of new drug treatments. So it allows us to study the different neurons that are in the brain, the other different cells that are in the microenvironment of the brain, which is a large conversation in our community. Is it the neurons itself? Is it also the environment of these neurons? Is it the reactivity to the amyloid and to the tangles that's causing Alzheimer's disease to progress as it does? So all of that requires tissue, and the best model of that, of course, is human tissue. Brain autopsy is also important because it can provide families with a definitive diagnosis, which may bring information and closure to loved ones. Very often, sometimes people are not quite sure why their loved one has passed or why they were having the changes they did, or maybe they do know and they just kind of want to confirm what was thought clinically with what we could find microscopically. It also helps family members assess their own risk factors for developing the disease and seeking help and making plans for the future, particularly in family members in that smaller group of folks with a more genetic predisposition for Alzheimer's disease. So I wanted to show also some images. We see the brains on our ends, and many people don't. So I wanted to demonstrate the difference between a normal brain here on the left versus an Alzheimer's brain here on the right. What you'll notice is the normal Alzheimer's brain looks more full. And what I'm pointing to on the arrow with the red arrow is what we call gyri. So they're nice and full and robust. Here on the right side, however, the arrow's not quite pointing on the folds, but it's pointing to the spaces. So what the spaces represent is a loss of tissue or a loss of cells. Your brain is composed of many, many neurons. When somebody develops Alzheimer's disease, those neurons die. And as neurons die, tissue will also what we call atrophy or shrink. And that's why the brain on the right side appears smaller, more wrinkled, and with more open and wide spaces as demonstrated. This is another image, again, demonstrating the normal brain on the left and the Alzheimer's brain on the right. This time looking at it from a lateral view, side view. Again, the brain tissue is quite full. The spaces are minimal. It's pretty tight, as opposed to the brain on the right side, which shows that their spaces are quite wide, and this brain is quite atrophied or shrunken due to the loss of neurons as a sequelae of Alzheimer's disease. Another schematic here of the brain demonstrates on the top in A and B, normal brain, and C and D represent a brain of an Alzheimer's disease patient. So the top two images in A is also a lateral view, side view of the brain, and B is what happens when you take that lateral view and let's say you're looking at the brain smack in the middle as if we cut it in half. So this is what we call the medial aspect in part B. Again, you can observe from the top images compared to the bottom images that the top images are much more full and robust. The spaces between the tissue are much smaller and tighter than those at the bottom, demonstrating Alzheimer's disease. Now, these cartoons are what we call coronal sections of the brain. So it's as if you have the brain head on and you've cut it from the anterior part to the posterior part. Now, this as a neuropathologist is what we also look at so that we can observe and notice the changes from the cortex here labeled cerebral cortex to the white matter, which is the lighter tan area. Areas of interest in Alzheimer's disease, of course, are your hippocampus. And it's also very intimately related to what's called your entorhinal cortex. These areas are the primary areas that are affected by Alzheimer's disease initially, and that is why you develop, as a first kind of change in Alzheimer's disease, most often a change in memory. So here on the left, the hippocampus, again, just like what we saw in the full brain, looks robust, looks full, not much space here, as opposed to the image on the right. Before I zone in on the hippocampus, let's look at the brain as a whole, even on this cut section. You have shrinkage of what we call the cerebral cortex. It doesn't look as robust and kind of smooth as it did in the left image. Also note these wide open spaces as we saw in the full brain from the loss of neurons and the shrinkage. When you have loss of tissue and shrinkage, you also develop an enlarged ventricle, not because you have more fluid in there like in hydrocephalus, but because you're losing tissue. And when you're losing tissue and shrinking, areas of space only become larger. And that's what's happening here when we focus in on the hippocampus as well. The hippocampus has become markedly shrunken due to neuronal loss in this area and Alzheimer's burden. And then the space, what we call the parahippocampal space, has become extremely widened. Again, this is actually a real life image of this hippocampus, which is starred here on the left and pointed to in the arrow on the right. The one on the left it's a little bit shrunken, but not as severe as the one in the right image, where you have a lot bigger space here. So after we get to look at the brain, what we call grossly, meaning with our own two eyes, we cut the brain, we're looking to see if there's any differences or change. What we now do is take those areas of brain and we look at it microscopically to see the things that we can't see with the naked eye, such as amyloid plaques and neurofibrillary tangles. So that we examined standard 15 sections. We take them from various regions of the brain that I showed you from before, the frontal area, the temporal area, the occipital area, and we sample all of those areas. Sampling this many regions of brain is something that could never be done while someone is alive. Again, emphasizing the importance of autopsy and why it's needed. So as I alluded to a little bit before, the pathologic changes in the brain that are responsible for Alzheimer's disease are abnormal deposits of proteins known as amyloid plaques and tau tangles throughout the brain. And what they do is they stop healthy neurons from functioning, And then that leads to the loss of connection from neuron to neuron, causing neurons to die. So on the left, what we have causing this brown pigment is a special stain or an immunostain that picks up beta amyloid, these plaques. So it specifically picks up the antibody amyloid, which is what these plaques are made of. And you can see in this brain, this is a lot. This is pretty much a dense a burden of plaques in this patient. And here on the right side, again, the brown pigment is a particular antibody, this time picking up what's called tau. And tau is the antibody that's found in what we call neurofibrillary tangles. And again, it is very, very dense. And whatever is staining brown is telling you like this is the amount of burden of the tangles in this brain. So here, if this represented the majority of the sections in someone's brain, this would definitely be considered a severe Alzheimer's disease case. For comparison, on the left side, this is without using those special immunostains tagging the proteins in the color brown. This is what we call our normal H&Es. And this is a normal brain on the left side for the most part. These are your neurons. If you remember from science, you have like your cell body, you have your nuclei, and you have little nucleoli, and it looks, you know, nice. And they're kind of doing their thing, look pretty normal. Then on the right side, you notice here centrally, this is also a neuron. However, the cytoplasm of the cell body isn't as clear. You have this kind of dense filamentous material, which is actually the neurofibrillary tangle. You don't see the cell body as nicely. You don't see the nucleus or the nucleolus as nicely. And that's because this neurofibrillary tangle composed of tau is basically impairing this neuron, and it's going to impair it to a point where it's going to die. Other microscopic findings that may be associated with Alzheimer's disease is something we call congophilic amyloid angiopathy. It is an accumulation of amyloid in the vascular cell wall. And we see it also as people get older, it tends to be associated with Alzheimer's disease, but it's not diagnostic of Alzheimer's disease. It causes weakening of the blood vessels, so it could increase the likelihood of cerebral bleeds. Another microscopic finding that's associated with Alzheimer's disease is what we call granulovacuolar degeneration. And as the name suggests, if you break it apart, there are granules, right? These little granules. And there's also vacuolization. So it's like kind of a little bubbling, which you can see a little bit here, which is also a degenerative change, telling you that neuron is going through a manner of death due to neurodegenerative disease. The other thing I wanted to emphasize with all this microscopic studies that we do and with all this tissue, the biggest thing that we're able to do is use this tissue to experiment and look into novel ideas so that we can better understand Alzheimer's disease. Here illustrates one of the papers, or one of the many papers you could see from the bottom that were able to be published based on samples from a multitude of brain donors, so that we could look using proteomics, which is one of the high throughput omics that is used as a methodology for us to compare different types of neurodegeneration. And I'll show you what I mean on the next slide. But basically what we had done is we used the microscope to help us, and this is a very special microscope. It's actually, it's part manual and it's part automated. And what we would do is we would select areas on the tissue. This is what the tissue looks like when we're going to create a slide microscopically. It's paraffin embedded. And what we did is we're able to cut out select areas, let's say in the hippocampus, and we wanted to just isolate neurons and compare those neurons and see what kind of proteins we find in them. That's something we were able to do with this methodology. Some of the many things that we were able to assess from this methodology was that we were able to compare what's known as rapidly progressive Alzheimer's disease versus CJD, which I described as a prion disease. Prion diseases, you need to know if you have that because one, you can have symptoms and then die very shortly after. And also prion disease, if the brain is open, it's also infectious and no one would want that. So it's pretty important to be able to determine the difference between people who would present the same. So basically, we were able to use the technique that I showed you in the previous slide to determine the difference between two groups of people who would present clinically similarly, but it's only after with using brain tissue from autopsy brains that we were able to distinguish the difference between the two. So just to, oh, sorry, I cut off the top part of my title, but it still is in reference to the same study. So basically, just so you could see a little bit for rapid Alzheimer's disease versus what we call sporadic, we had a group of 22 patients, male and female, 22 patients, male and female, approximately around the same age, 70 to 80 years old. And they both had a disease duration which varied from 9.2 months to about 122 months. And they died, well, this is a different postmortem interval, but the disease duration is basically how long they had the disease before they died. And these are just kind of details of the area that we sectioned, how many plaques we took. And again, all that is derived from human tissue from the donated cases. The big take-home message from this particular study was that we were able to identify 279 plaque proteins that were consistently detected in every patient, regardless of rapid AD or if they had sporadic AD. So out of 1,935 total proteins quantified, the thing, as I mentioned, that's most important is that 279 were found 279 plaques that were found were consistently detected in both of those groups. The big take, I know we can get lost in a lot of this jargon, but the most important thing to take away from this is that this study would not have been made possible without human tissue. There's no way we'd be able to know or look at a total of 1,935 proteins in anything but a human brain. There have been studies that have been done in mouse models, but they don't quite align with the complexities of what is the human brain. So here are just some of the proteins that were identified. Many of them are already known to be involved with Alzheimer's disease: A beta in the plaques, tau in the tangles, apolipoprotein E, which I've mentioned before in like familial cases. And at the same time, 39 novel proteins were identified. Thus, these are proteins that have not been previously associated with Alzheimer's disease in the past. So these studies are not only able to confirm what's already been known in the literature or what's thought of in the literature, but these studies are also able to elucidate some new proteins and some new possible targets for treatment. So this is just a schematic, again, just emphasizing the importance of brain donation and what it contributes to research. Research that we're able to share with a multitude of investigators around the world. Research that's able for us to compare with biomarker modalities, as I mentioned, so using imaging while someone is alive to be able to detect amyloid and tau burden, and maybe in the future not having to only rely on autopsy tissue, and also biomarker technology that's being looked into and using blood and or CSF to also detect those same things. So this is, again, the same slide that I showed in the beginning, just to double down on the importance of brain autopsy. As I've already mentioned, it's the gold standard for definitive diagnosis, but because the biomarker tests are still in the research phase and not used clinically, it's very important for us to be able to compare our gold standard of autopsy findings with these biomarker tests, so that in the future that we're able to detect Alzheimer's disease while people are alive much earlier and hopefully have targets to cure and or slow down the disease. Brain autopsies are also important in allowing us to study molecules, as I said, to develop new drug treatments. Drug treatment that has been talked about since 2023 is Leqembi. It is approved by the FDA, making it the first disease-modifying therapeutic holding traditional approval for the treatment of Alzheimer's disease. The benefits of it and the use of it could be better discussed by my clinical colleagues at the Alzheimer's Research Center, but as neuropathologists and folks who are looking at postmortem brain tissue, this is also going to become important because those people who are using these drugs or these nuanced drugs, everyone is going to die at some point. And whether it's from Alzheimer's disease or something else, the sequelae and long-term effects of these drugs are going to be able to be looked at in an autopsy brain and compared with the clinical observations in these patients. And many of the other points below I've mentioned before, in being able to share the tissue with a multitude of investigators and providing families with the definitive diagnosis to bring closure to loved ones and also help family members assess their own risk factors for developing disease. I put up this slide because I wanted to also just remind everyone that along with this Lunch and Learn, along with the importance of brain donation, the Alzheimer's Disease Research Center issues a newsletter just about every year. And in that year or every season, it's going to discuss things that we're doing clinically. It discuss papers that have come out more recently, whether it's from the postmortem brains or whether it's from, our psychosocial divisions or our clinicians who are reminding us to eat better, exercise, and so on. And it's just such an amazing resource. And I'm pretty sure that those of you who are in the meeting have already taken advantage of this. But I just wanted to remind everybody of this resource. Again, Mind Matters, we had an issue out just recently talking about AI and early detection of Alzheimer's disease. Again, these are research modalities that would be great to compare to our gold standard of autopsied brains, looking to the future to improve the diagnosis of this disease. As I've mentioned already about Leqembi, it was a topic that was broached in our Mind Matters newsletter last year. And last year as well, we also had discussed the nuance of biomarkers. And although it was being used in a research capacity, how us as a center and many centers across the country are looking to use this modality as a potential to diagnose Alzheimer's disease much, much sooner. So with that, I would also want to remind you all about the process of brain donation. At the time of death, all tissue rapidly begins to degrade. So in order to ensure the greatest research and diagnostic value for brain tissue, it's essential that the brain is removed as soon as possible after death. The brain removal is performed carefully and respectfully by an experienced professional, myself and others, and it will not interfere with any plans for funeral services. I let you know this so that maybe you can let your loved ones know, because at this time it's very delicate when someone is grieving and someone passes, and for them to be so selfless as to contact us for the brain donation. And it is something that we definitely appreciate, and it's something we definitely treat with a lot of respect. And with that, we also like to provide a lot of information about the process. So if anybody at any time has more questions about the process, we're happy to answer it. And with that being said, all persons involved with the care of the donor should be aware of the planned autopsy, because as I said, it's very delicate, and it's really good to talk about that up front. Thank you all for your attention, and I hope that this was a bit enlightening. Thank you.